all layers. Let's first talk about extraluminal compression. This is a case who were transferred to me for the evaluation of suspected subepithelial lesion. The local doctor palpated the area with a forceps and he felt it is very firm lesion. When I put my scope into the patient, I cannot find any subepithelial lesion-like area. And then I put the switch on of endoscopic ultrasound, and I cannot find any mass lesion, intramural mass lesion. But when the place where the doctor had seen something, I can find many vascular structures compressing the gastric wall. So sprained vessels compressing gastric wall can be misdiagnosed as subepithelial lesion. This is my data when I performed 2,800 suspected subepithelial lesion in US. I found about 8% was extraluminal cases. Among them, 15% was pathological lesions, and the rest were normal structures. For normal structures that I can see through esophagus was aortic aneurysm, lung cancer invasion. Pathological lesions were aneurysm, aortic aneurysm, lung cancer invasion, and TB lymphadenitis. And for the stomach, hepatic cyst, splenic cyst, pancreatic cyst, and renal cyst. And for the duodenal lesions, pancreatic cancer invasion, sometimes choledochal cyst. Sometimes minor papilla are misdiagnosed as subepithelial lesion and transferred to me for further evaluation. Yeah, this is the image of aortic impression and lung cancer invasion and splenic impression. On the right hand side, hepatic cyst and choledochal cyst and normal minor papilla are seen. Let's move to the talk about US evaluation of subepithelial lesion. There are so many causes of subepithelial lesions. Common lesions in esophagus is leiomyoma and granular cell tumor. For the stomach, we can see GIST or heterotopic pancreas. For duodenum, GIST, brunal gland hyperplasia, carcinoid lipoma are frequent. This is data from Korea. You can see in the esophagus, leiomyoma is common and granular cell tumor is the second. And for stomach, GIST or smooth muscle neoplasm like leiomyoma was the most frequent one. But with EUS, it is impossible to differentiate completely GIST from leiomyoma because it is only differentiated by special immunohistochemical stain. Pancreatic rest was the second one. For duodenum, there is cyst and brunal gland hyperplasia. For rectum, carcinoid tumor was the most frequent one, and GIST sometimes, and lipoma and lymphangioma. With endoscopic ultrasound, gut wall layers are seen as 5 well-preserved wall layer structures, and the correlation between endosonographic layer and histology is well proved. The first and second layer are mucosa layer, and third whitish layer is submucosa layer, and the fourth hypoechoic layer is muscularis propria, and the fifth layer is adventitia or serosa. So when we want to differentiate the subepithelial lesion, what should we see? The most important thing is find out the originating wall layer. So we should observe the transition zone. And the echo texture, is it hyperechoic, hypoechoic, isoechoic, or anechoic? Is the echogenicity is homogeneous or inhomogeneous? Does it have any hyperechoic spot or anechoic area? We should examine the echo texture and also see the margins is irregular or regular. And we can measure the size, and the vascularity is also important. If it is a malignant lesion, we can see lymphadenopathy around there, and we can see the lesion is invading the adjacent organs. This is US characteristics of various subepithelial lesions. GIST and leiomyoma is always from the fourth gastric wall layer, and it is hypoechoic. Aberrant pancreas involves the second, third, and fourth wall layers and mixed echogenicity. The wall is margin is sometimes irregular. Lipoma is third wall layer origin hyperechoic lesion. This is a video clip of gastric cyst. You can see the fourth wall layer origin hypoechoic mass is seen in the middle of the video. It has some hyperechoic spots inside, and the fourth wall layer transition zone is well observed. Next video shows hyperechoic mass lesion arising from third gastric wall layer. It is a mucosa layer, hyperechoic, so it is lipoma. So if the lesion is typical, you can tell which is which. This is my data quite a long time ago, sorry for that. When I observed the 622 suspected vectorial lesion, I can tell the EUS expression was myoma or cyst or malignant lesion, inflammatory lesion, ectopic pancreas, carcinoid, and so on. And when it was compared with the final pathologic diagnosis after resection, I can find that the accuracy of EUS impression was 78.4%. So the EUS impression is not 100%. That's why we need tissue diagnosis to have definite diagnosis. The diagnostic accuracy of EUS and EUS-FNA and EUS-FNB is very various. It depends on depending on the authors. It is because the needle use is different, the location of the tumor is different, and do they have any cytopathologists inside the room or not, and the method they are using is different, and the experience of the endosonographer is different too. This is two-cut biopsy needle. When we want to see the histologic architecture of the lesion, we need core biopsy. So previously we used two-cut biopsy needle. It has firing system on the handle, and when you put the needle inside of the tumor, we can get tissue core like this. If we stain it, we can find it out that this lesion is cyst. But there were some technical difficulties with two-cut biopsy needles. A procore needle was developed. It has various diameters, and if the lesion want to pass through the duodenum, it is easier to do with procore needle than two-cut biopsy needle. The needle is going into the mass lesion, and if the needle is well positioned, we can remove the stylet and we can see the hole on the side. When we move the needle to and forth, we can see the tissue is sliced like cheese into the needle. So after removing the needle, if we put the stylet back in there, we can get lots of core tissue. But frankly, I have never got this amount of tissue before. This is a procore case. It is a mass at the cardia, and I got core tissue. It was proved as a leiomyoma. This is my paper comparing 22-gauge aspiration needle and 22-gauge biopsy needle. Sometimes we can have diagnosis with the FNA needle, but cytology is sometimes not enough. So we compared two groups of FNA and FNB, and after performing three passes, and if we cannot get enough tissue, we did a crossover study. So the only 2 cases had the diagnosis with FNA needle, but 9 cases, 75% had the diagnosis with FNB. It is quite lower than the usual report because we did only 3 passes. After that, we performed the crossover, and among the 7 crossover cases, we can get diagnosis. 5 of them. For the FNB group, for 2 cases, we cannot get any cytology diagnosis. The complication happened only 1 case in FNA group, so FNB is not more dangerous than FNA. This is an interesting case and which shows the diagnostic usefulness of EUS-FNA. This is a rectum. There is a stenosis of rectum, and the mucosa looks normal. It is stenotic, and the scope was difficult to pass through. And the CT and MRI was taken. We can see a massive region on the right side of the rectum invading rectal wall. It was PET positive. EUS-FNA was performed, and we can get pus-positive filaments from there. It was actinomycosis, and the patient was healed with antibiotics without surgery. Now let's move to talk about endoscopic tumor resection. Nowadays, endoscopic therapy is well established, especially EMR and ESD, and we are doing a lot of them. And if the lesion is confined within the mucosa layer like this one, this is from the muscularis mucosa, only EMR is enough to remove the lesion. But if the lesion is deeper and it is from the muscularis propria, we need to expose the mass first to avoid complications. So after expose the mass, and then we can dissect the beside the mass lesion. This is a stroma case, and we can see it is also from the fourth gastric wall layer. And I'm ungrouping the overlying mucosa and the submucosa and try to expose the mass and dissect the reason out. This is another interesting case. This patient was transferred to me because he was diagnosed as carcinoid after routine polypectomy. So the local doctor was really bit worrying about the remnant carcinoid tumor, and I did EUS, and I can find a small remnant carcinoid tumor within the third wall layer, and I performed one more procedure of EMR to remove the remnant carcinoid tumor. This is a very large carcinoid tumor, and the mass is confined within some mucosal layer with EUS. By the guideline, the carcinoid lesion larger than 1 cm should be removed surgically, but I can confirm that the lesion is confined within some mucosal layer, and I cannot see any perirectal lymphadenopathy. Then I can perform ESD to remove the lesion, and the patient is healthy and stable more than 5 years now. My final topic is follow-up of subepithelial lesion. When you see a subepithelial lesion, we evaluate it with EUS, and if it is normal extramural organ or lipoma, we don't need to do further evaluation. But if the lesion is a cyst and it is less than 3 cm or it is glomus tumor, we can consider to remove it or regular follow-up. And if the lesion is carcinoid and it's larger than 3 cm cyst, it should be removed. This is my recommendation after EUS evaluation. If it is intramural lesion, we can see the originating layer, and if it is located in the mucosal layer, we can get tissue via deep biopsy, and we can see what it is, and if it needs to be removed, we can do EMR. If the lesion is in some mucosal layer and it is very typical hyperechoic lesion like lipoma or pancreatic rest, we can just observe and follow it. But if the lesion is not typical, it does not have typical EUS feature, we can try to ungroup and biopsy deeply, or we do EMR or EST to get tissue and remove its diagnostic and the therapeutic together. If the lesion is from muscularis propria, it might be cyst, leiomyoma, schwannoma, glomus tumor. So if the lesion is less than 1 cm, we can follow up clinically and endoscopically. If the lesion is between 1 to 3 cm, we can perform EUS-FNA or EUS-FNB, and if it is CD117 positive, we are going to remove it surgically or via ESD because it is cyst. If it is negative for CD117, if it has high risk features like calcification, anechoic area, and irregular margins, and we can try remove it, but it does not have any high risk EUS features, we can follow it up. If the lesion is more than 3 cm, we can recommend surgical resection. It is my summary. Subepithelial lesions are frequently found during endoscopy. Extrinsic compression may mimic subepithelial lesion. US can accurately differentiate a mural lesion from an extrinsic compression against the gut wall. Differential diagnosis of intramurals of epithelial lesions based on US features such as layer of origin, internal echo characteristics are quite accurate for typical lesions. US guided sampling of epithelial lesion helps definite histologic diagnosis. US also can guide therapeutic plan and follow-up of subepithelial lesion. Sorry, it was Zuba.
Thank you, Professor Kim, for a very clear and informative presentation about rural US and type epithelial lesion around the GN tract. We have a few minutes, so we can allow one question from the audience. Any question from the audience? If no, thank you, Professor Kim, for a very clear and impressive presentation.